Well, we heard a great presentation today, a debate between Dr. Shipley and Dr. Amling about adjuvant versus early salvage. And what I came to listening to their debate is that they really essentially agreed. It wasn't that vigorous a debate. In the era when the 3 large adjuvant trials were published, most of the patients had a PSA under 0.2. These are patients who had radical prostatectomy, adverse pathology, and then they were randomized to adjuvant radiation therapy or observation. If you look at the trials carefully, about 70% of those patients had a PSA under 0.2 after radical prostatectomy and before randomization. So there's quite a few patients who actually had detectable PSAs. So that's interesting. And now we have a sensitive PSA test that can measure PSA down to 0.01. So about a third to a half of the patients who have adverse pathologic features and are observed without radiation therapy will be disease-free. So I think many of us think that, gee, it certainly makes sense to measure a sensitive PSA after surgery. And if it's undetectable, we might be able to save that patient radiation therapy safely. And when we pull the trigger to give them early salvage, we're now giving salvage therapy at very low PSA levels. So much so that those patients are very much like the patients in the adjuvant trials. Their PSAs are only 0.1 or less sometimes when we'll initiate early salvage therapy. So I think the outcomes of early salvage are pretty similar to adjuvant. The real benefit of measuring sensitive PSA is saving some patients unnecessary radiation therapy if they have persistently low sensitive PSAs.